Once again, good morning, everyone. In case you don't know me, my name is Sharon Hovland. I'm a fellow lamb patient. I was diagnosed in 2012 at Mayo Clinic in Minnesota. I'm also the volunteer lamb liaison for Region 12, which, as I said earlier, if you were on, includes Minnesota, the Dakotas, and Wisconsin. I've been doing that since 2014, so I'm going on 11 years now. And this is my sixth year coordinating this, or my sixth time coordinating this Q&A session. So it's becoming kind of an annual thing since COVID, when we had to cancel our regional meeting at the last minute. So nice to be here. I'm also joined by Erin Williams, the patient outreach coordinator from the Lamb Clinic, or I'm sorry, from the Lamb Foundation. Many of you may already know her. She's in charge of technology today, so she'll be running the Zoom meeting. And if there's any questions or topics that come up during the meeting that we need to follow up on outside of this session, she'll take note of those and we'll follow up within a week. Oops, Erin, we got a rogue microphone again. All right, thank you. So thank you, Erin, for being here this morning, giving up your morning, and to the Lamb Foundation for their ongoing support for our educational meetings. We really appreciate it. Of course, Erin is just one of an impressive group that we have joining us today from the Lamb community, which includes women living with Lamb, our friends and family members, volunteer Lamb liaisons from multiple regions in the US and Canada, and 3 of our incredibly dedicated and hardworking Lamb Clinic directors, who I get to introduce to you today. Our first Lamb Clinic director, Dr. Misbah Bakir, has been with us since our first Q&A session in 2020. Dr. Bakir was born in Saudi Arabia, but she was raised, educated, and attended medical school in Pakistan. She came to the US in 2002 and did a residency in internal medicine in Philadelphia. She then moved to Denver, Colorado, where she was a hospitalist and did bench research at National Jewish Hospital. In 2009, she started a fellowship in pulmonary and critical care at Emory University in Atlanta. And in 2012, she did a 1-year fellowship in interstitial lung diseases and vasculitis at Mayo Clinic. She loved our Minnesota winters so much that she accepted a role on the faculty at Mayo and is currently an assistant professor, director of the Lamb Clinic, and program director of the Interstitial Lung Disease and Vasculitis Fellowship. Next is Dr. Gupta. This is his second year joining us for this session. He's a professor in the Division of Pulmonary, Critical Care, and Sleep Medicine at the University of Cincinnati, where he serves as the director of the Interstitial and Rare Lung Diseases program. Dr. Gupta's clinical and research focus is in the field of rare lung diseases, such as LAM, and his work is aimed at better defining the natural history, improving detection, and developing novel treatment modalities and monitoring strategies for patients with LAM and other rare lung diseases. And joining us for the first time this year is Dr. Matthew Koslow, an assistant professor of medicine in the Division of Pulmonary, Critical Care, and Sleep Medicine at National Jewish Health in Denver, Colorado. He completed his internal medicine residency at Albert Einstein College of Medicine in New York, a pulmonary fellowship at Mayo Clinic in Minnesota, and advanced lung disease and lung transplant fellowship at Inova Fairfax. Dr. Koslow specializes in the care of patients with interstitial lung diseases and serves as associate director of the Lamb and Rare Lung Disease Clinic. He is also the co-chair of the Clinical Advisory Board for the Lamb Foundation. His clinical research focuses on advanced imaging techniques to predict disease progression in interstitial lung diseases and improving the quality of life for patients with rare lung diseases. Welcome to all of you, and thank you again for taking your time to be here with us today. And thank you too to everyone that submitted questions in advance of today's meeting. We got some fantastic topics submitted. The doctors received them a week ago and have put time into researching them. And I just want to make sure that the doctors know how much we appreciate all the time and effort that you put into this year, every year. It really has a huge impact on our community, to the point where we've had people request to join this meeting today that are outside of the invited regions. They were so excited to learn from your expertise. So thank you again. And with that, let's start with our first question, which is for Dr. Gupta. Dr. Gupta, are there new findings from the latest LAM studies that provide hopeful results for either new medications or a cure?
Yeah, hi Sharon. Happy to tackle that question. Hi everyone. I should say that as you were before a little digression, as you were describing Region 12.
Yeah.
So last year our summer vacation was a road trip from Minnesota to South Dakota to Wyoming, and I had no idea that unbeknownst to me, we planned a summer vacation as if we were going through Region 12. But
You
uh,
should have let us know. We would have brought out the welcoming committee.
Coming to the question at hand, absolutely, there is, uh, we are in a lot of ways fortunate in LAM that there is a lot of momentum across multiple labs trying to study LAM at a very high resolution. And over the past few years, there have been several candidates for therapies that have been discovered this way. And LAM is also one of the few rare diseases that has had multiple clinical trials in various stages looking at those therapies. And over the past few years, especially with the advent of technologies like single cell, which are allowing us to look at LAM directly from human tissues at a very high resolution, we are unearthing new molecules, new candidates that can be used for therapies, which we and the entire field, I think, is quite excited about. Happy to go into specific agents, but I'm trying to stay away from those because they really need to be tested in a very phased, gradual manner in human trials before we start advocating that this might or might not be a potential strategy. But speaking generally, there is a lot of enthusiasm and there are a lot of potential candidates. We do, as a field, need to grapple with how to best test them, though, because that for me, I think, is the fundamental dilemma. Because, and in a way, a good problem to have, because post sirolimus, it is difficult to identify how are we going to test whether a compound is more efficacious either by itself or when added on top of sirolimus. But that's, I suppose, a topic for a separate day, but something as a field we need to grapple with.
Great. Are there any ongoing research projects that are looking for patients to participate, or any new studies that you know about that are coming up?
Yeah, good question. Well, on that front, first, I should say thank you to everyone, because this has been a theme to highlight from the get-go, and that when you're dealing with a rare disease, you need patients to be an integral part of the discovery process. And the LAM community is an exemplar that we can, when we can and often do, portray to everyone as a community that has gone through this journey together. So thanks to everyone who routinely participates in research. On amongst the more recent things, a couple things to highlight. There is the MILD trial, which is taking a step back because some patients may be new. So the MILD trial a few years ago showed the efficacy of sirolimus as the treatment for LAM. But in order to be in that trial, you had to have lung function less than 70%. The MILD trial now is looking at patients with normal lung function, whether we should treat them with early sirolimus or not. So this is just an update that the MILD trial is fully enrolled. The last patient's last study visit is actually in May of this year. And we are anticipating and hoping for some top-line results reveal at the LAM conference in this fall. So that's another plug-in for the LAM conference for people, if they are not aware of, to start thinking about and planning for that. So thank you for everybody who participated in MILD. We are really looking forward to those results. Similarly, thank you to everyone who participated in the menstrual variation in LAM study. That study is also done enrolling. We'll still have room for a couple of patients if you are not on sirolimus and don't have cyclical variability in symptoms. We could still enroll, but otherwise that study is also enrolled. And again, thank you for participating. There are the protocols at NHLBI with Dr. Moss, which are always looking for patients to define the natural history. And even if you're not enrolled in a trial, it is a good idea as you're going to the lamb clinic to ask your clinic directors if there are any ways that you can participate in research. It may be something as simple as contributing to natural history data. It may be giving a blood sample that can be then used for biomarker work. And last but not the least, stay up to date on the things from the Lamb Foundation, which also has a page for the currently enrolling studies and trials that gets updated with regular information.
Great. Can you explain the compound RMC 5552 that the Lamb Foundation recently highlighted in one of their communications?
Yeah, happy to, although I won't go into too much detail simply because of the rationale I gave for the first question, and that this and any such compound that looks quite exciting at the bench level really needs to be tested in a phased manner before we get too excited about it as a potential human medication. But very broadly speaking, the pathway that is the central driver for LAM, so the mTOR pathway, as some patients are probably familiar with, sirolimus, the reason it works in LAM is that it very exquisitely and in a very targeted manner reverses that pathway that is driving LAM. But sirolimus only acts at about half of that pathway, and there is another arm of that pathway that sirolimus is not acting upon. And this compound is sort of a modified next generation sirolimus, if you will, that acts on both arms or both sides of this pathway. So theoretically, this could more completely and more effectively block the mTOR signaling than sirolimus by itself can. And in preclinical data, that looks promising. Conceptually, that looks quite promising. So we are all excited about it, but right, the balancing act there is that mTOR is also a very central pathway that is important for every aspect of our normal functioning. And if you block it more fully, are you now at more risk for side effects? And that's the thing that we really need to study in humans. That's exactly why a little bit of the tempering of the enthusiasm from my side is that, yes, it's conceptually very exciting, but we need to see if patients can actually tolerate it and take it in a safe manner before this becomes a therapy.
Can you provide an update on the status of VEGF-D tests being processed at Cincinnati Children's? It seems that they're being processed again, but what's the current expected turnaround time?
Yeah, good question. Again, a step back there for people who may not know is that VEGF-D testing over the past few months had been put on hold because of supply chain issues that I think at some level all of us are familiar with in one aspect or the other of our lives. But those issues have now been resolved, thankfully. The lab is going through the backlog of tests that were submitted over the past few months. The current anticipated wait time is about 4 to 5 weeks. Previously, it was about 2 to 3 weeks, but we are hoping that in the next couple of months, that backlog can be cleared and then it'll be back to the 2 to 3 weeks.
Yes. I've heard from a lot of people that are waiting on that, so I'm sure everyone's happy to hear that. Do the cuts in federal grants impact LAM research?
I don't know that there is a good answer to it. And probably yes, but I will say that I don't know that there is any specific impact on LAM. What I mean by probably yes is that these cuts probably have an effect, a deleterious effect on research across the board. And if that is the case, that it will probably also have a domino effect on LAM, although I don't know that there is something specific that LAM will be more affected than the others.
We don't know of any current impacts at the moment.
At the moment, no. If I'm speaking very selfishly, then I could say that our Rare Lung Disease Consortium application, which we also included LAM work, that study section was canceled, and we don't know when it's gonna meet. So that's a potential impact that I'm aware of, but that may just come right back as scheduled, etc. So no, I'm not aware anything specific right at this moment, but it is potentially possible that it has a negative effect.
Thank you. There are a lot of people that were asking about that. Dr. Kozlow, we'll come over to you now. Are there any liver issues associated with LAM disease?
Well, welcome to everyone. I'm really happy to be part of this as the first time. So just wanted to take that opportunity to thank you for the invitation. The answer is yes, and I think it's probably an opportunity just to perhaps briefly review for people that may be more or less familiar with what LAM is. LAM is the proliferation or the increase in the LAM cell, which is a smooth muscle cell. And most of us know it as affecting the lung. So we can have lung manifestations, but it can also have manifestations outside of the lung. And these can be in different forms. So we think of LAM cells as forming clusters, and the manifestation in those organs kind of depends on where they end up. So in the lung, they can cause cysts. Outside the lung, they were familiar with a lesion called an angiomyolipoma, which is a benign tumor. I would imagine that some of the people on this call would be familiar with that because we're typically screening for that. And typically that's in the kidney, but it can manifest in the liver. So this would be a benign type of tumor associated with LAM that would also appear in the liver. But then there are other manifestations. I had to actually look this up, but cluster of LAM cells is often how it might be referred, but those apparently can be more burdensome and appear as a liver mass or a lesion, let's say, that might be appreciable on an imaging test. I think that's rare and on the version of case reports, but that can happen, and it speaks to, I think, the necessity of having a specific diagnosis when you have these perhaps incidental findings on imaging. And I think those would be the main hepatic manifestations that would come to mind, AMLs for short, or these LAM cluster cells that might appear as liver lesions. Anything else, Misbah or Nishant, that you've come across?
I think according to one study, the incidence is it's like 2%. It's very rare to have hepatic AMLs.
Yeah.
Yeah, no, I'd agree with that. So hepatic angiomyolipomas are not uncommon in patients in women who have tuberous sclerosis associated LAM. They tend to have a lot of kidney AMLs, and not uncommonly they get liver AMLs even as frequently as 30% of the cases. But in sporadic LAM, which tends to be the vast majority that we see in the pulmonary LAM clinics, the hepatic AMLs are very uncommon.
Dr. Kozlow, can LAM cause pulmonary hypertension? And can diet and exercise help prevent it or reverse it if you already have it?
So I'll take the first part of that question. Can LAM cause pulmonary hypertension? The answer is yes. And it's an opportunity just to briefly describe what pulmonary hypertension is or how the community thinks about it. It is also a rare condition, and it's divided into 5 groups. So the first would be group 1, and we think of that as associated with autoimmune conditions. And then the second is associated with heart, the third with lung, the fourth with chronic clots, and then the fifth is rare lung disease. So you have this LAM where kind of specific or formally is characterized in the group 5, which is defined as a mechanism that's unclear. Yet most patients with LAM have lung disease. So that would be one way to answer it. I found 2 studies that specifically address this. There might be more, one out of Brazil and one out of France, and they share similar findings, which I could summarize as it is possible, it's rare. or not rare, it's uncommon manifestation of LAM. When it does present relative to other lung-associated pulmonary hypertension conditions, it's more on the mild side. The third thing to comment about that is it typically also correlates with lung function, also similar to other lung-associated pulmonary hypertension, but not always. So the problem with pulmonary hypertension, or the problem with chronic lung disease, is that we get low oxygen levels, and those can cause vasoconstriction in the blood vessels of the lung. And so it's logical that the manifestations in the vasculature, in the blood vessels, would associate with lung function. These studies both cite that that is common, but not always. And it raises question of whether there's some other mechanism besides the lung function itself that could cause pulmonary hypertension in LAM patients. And it sort of maybe speaks to the previous question of whether there are manifestations outside the lung, for example, in the blood vessels of the lung that may manifest. The other thing I would say is relative to other lung-associated pulmonary hypertension, there's a term that's somewhat loosely said as out of proportion pulmonary hypertension, where patients with lung disease would get more severe pulmonary hypertension that you would expect. And that doesn't really seem to be the case overall with patients with LAM that may get pulmonary hypertension. That said, we should always screen for it, especially when the symptoms don't match up with the patient's condition.
Okay.
The second part of that was, can diet and exercise help prevent it or reverse it? That's a tough question. I think there are other questions that might touch on exercise, so maybe we might delve into that. But more specifically, I think with any chronic condition, especially lung and pulmonary hypertension, exercise is a big part of maintaining your conditioning, and we'll probably speak more to that. Diet, I'm not aware of any specific diet. It's a subject I love, but I will say I'm not aware of any specific diet that would specifically address this, but we can certainly go into that later as we address some of these other questions.
Okay, sounds good. Is there any research or recommendations for LAM patients with a borderline moderate FEV1? And the patient submitted this is at 76%, to start low-dose sirolimus treatment, or is the recommendation to wait until it drops to 70% or lower?
So interesting that question was directed to me, given my colleagues on the call. So I'll just take the opportunity to introduce what Dr. Gupta just mentioned, which was certainly a logical question, and I imagine the rationale for the trial MILD that Dr. Gupta pointed out, which is patients that are needing therapy. This is usually a lifelong therapy, and can we introduce therapy with less risk of adverse effects earlier in their disease state? So the rationale is there. As far as data, I'm going to defer to Dr. Gupta. I will comment that I think a lot of us have experience with patients that don't always tolerate the dose in the original studies. So oftentimes that becomes a case-by-case approach, depending on what the patient can tolerate and also their trajectory of their lung function. But as far as data, I'm going to defer to my colleague, Dr. Gupta, who just touched on that a couple questions ago.
Yeah, Matt, you've covered it well. I don't really know that I have a tremendous amount to add. I will say to this question, though, that let's take a step back. The MILDS trial that showed the efficacy of sirolimus, we had to draw an arbitrary line of, as it always happens in a clinical trial, of who is eligible and who is not. That line was drawn at 70%. If you have a lung function less than 70%, you're eligible. If not, you're not. But I don't think any of us believes that there is anything magical about 70%. And the question is very intuitive and very logical. Why, if my lung function is declining, why should I sit and wait until it reaches some 70% threshold? Why shouldn't I try to preserve it while it is more normal? And that very question formed the rationale for the MILD trial that I've already spoken about, that we will have results later this year. In the absence of that MILD trial data, what we do in the clinic is exactly as Dr. Koslow said, we follow everybody's lung function closely. And if we are declining rapidly, or more than the average rate of decline in LAM, we often do institute therapy before that 70% threshold is met. And if you look at the LAM guidelines from a few years ago, we wrote exactly that if you are declining more than, say, 90 mLs per year, or if you have other markers that suggest that you have a substantial or you have a fair bit of disease on the lungs. So it may be that your diffusion capacity is low, or that you're gas trapping on the lung function test, or that you're desaturating and requiring oxygen. So lung function is not the only parameter. We sort of take into account all of that. And for women who have substantial disease or they are progressing, we don't wait till the 70% threshold is reached. And in fact, that was a big reason why MILD took this long to enroll, because there were a lot of patients that we felt that they just need to go on treatment and that it is not fair for them to take a 50-50 chance.
Okay. The next question, Dr. Koslow, my pulmonologist is hesitant to start me on sirolimus because my pulmonary function tests are good for a 63-year-old. I also have Sjogren's and Raynaud's. Won't sirolimus help with my autoimmune condition as well? I was hoping to replace my azathioprine with it.
That's a very interesting question. There's a lot kind of to dissect with that question. So I think one thing, I thought of a few things looking at this question. First is just to characterize the differences between these two conditions. So LAM is what we would call a loss of function mechanism, that there is a loss of function in a gene that's regulating what we talked about, mTOR. It's also so why sirolimus, an mTOR inhibitor, is inhibiting this loss of function from the gene that's then promoting this mechanism that has the deleterious effects. That's different from Sjogren's, which is an autoimmune condition where your immune system is actually attacking itself. So two very different pathogenesis to these conditions. The second thing is Sjogren's. I think it's notable to say, I don't know if it's relevant in this particular question, but Sjogren's can manifest as a lung disease that is very similar to LAM and is often very important to distinguish LAM. So it does, I don't know if it's relevant to the patient that asked this question, but it is relevant to anyone reading that question to say, well, do we have the right diagnosis? Because Sjogren's can manifest as something called lymphocytic interstitial pneumonia, which is a cystic lung disease, or LIP, which we like to make everything short, which it can be quite similar, and also speaks to the earlier question about VEGF-D, because that was one of the ways that VEGF-D was validated as a non-invasive marker in a pool of patients with different cystic lung disease. VEGF-D was elevated in most of them, but not in the differential diagnosis, the other cystic lung diseases. So I just thought about that reading this question. But then more specifically to the question, the role of these treatments. So sirolimus is inhibiting mTOR, which is in the mechanism of LAM. Azathioprine is an immune suppressant medication, which is inhibiting the proliferation of someone's immune cells. So sirolimus also is an immune suppressant and used more in the transplant literature but not something that would come to my mind as a first or second line therapy for an autoimmune condition. That said, this is always an opportunity to go into look things up, and mTOR inhibitors have been used in refractory autoimmune conditions. The ones that I came across were more autoimmune conditions associated with cytopenias or low blood counts that can manifest as part of an autoimmune condition. That's probably the extent of knowledge that I can, or experience that I can comment on. Certainly there's no good data for that to the best of my knowledge. It is something that we commonly deal with when you have two coexisting diseases. Can you find one therapy that treats them both to limit side effects? I don't know that that would be the case in this question. The question was, would sirolimus help my autoimmune condition as well? That's the question. I was hoping to replace azathioprine. So I don't know. I'm going to stop there. That's probably the extent of my knowledge to answer that question.
That's fair. Okay, thank you. All right, Dr. Bakir, what is the recommended target trough level range for sirolimus for postmenopausal women?
Good morning, everyone. The trough is described as the lowest level of the drug before you are going to take the next dose. So because as we have discussed, that sirolimus is used in transplant world, especially renal transplant patients. And in transplant world, we really want to keep the target of these drugs at a specific level. And that's where the guidelines for the use of sirolimus have come from, even in our LAM patients. So the recommended trough level is 5 to 15 nanogram per ml, which is the same between whether they are postmenopausal or premenopausal. That doesn't change with your menopausal status. Having said that, there have been some studies, although, as I said, the standard or recommended dose is 5 to 15 nanogram per ml, but there have been studies where they used lower dose, which is 1 milligram of sirolimus rather than 2 milligram. And in the studies, they said that the trough levels was like 3, and that was enough, around 3, and that was enough to maintain their lung functions. But we won't go into that much detail, but I just want to say that it doesn't change with the menstrual cycle status, but it is 5 to 15 nanogram per ml, which is the standard recommended dose.
I was recently diagnosed with LAM, and I'm anxious for my family to find out if I have TSC. I have lung and kidney cysts, hypermelanosis, and cousins with intellectual disabilities. Is genetic testing the only way to confirm this? And would it be helpful to visit a LAM clinic or a TSC clinic?
Yes, so just like a brief introduction, that when we say sporadic LAM, that means that a mutation happened after an individual is born, and it is sporadic, like it was not in the fetus or zygote. And tuberous sclerosis, on the other hand, is in the fetus, and that is associated with other anomalies. And there are many of them. Some of them, whoever has asked the question has mentioned, like it must be hypomelanosis and cysts and intellectual disabilities. There are many different tumor growths in heart or on the skin, and especially around the nail beds. But you don't have to have genetic testing or diagnosis to it. If you do it, it will support it, but you don't have to have a genetic test. You can make the diagnosis of tuberous sclerosis just based on clinical criteria. So in order to have so there are certain features which are into major categories. For example, this hypomelanotic or facial angiofibromas, like growths that I mentioned, like skin manifestations or renal AMLs, they are all into major categories, but there are some into minor categories. So in order to make a definite diagnosis of tuberous sclerosis, you should have two major or one major and two minor features. For possible tuberous sclerosis, you can have one major feature or two minor features. But this requires some expertise, people who are experienced in looking into these manifestations. So I would recommend that this should be, the person who has asked the question should be seen in LAM or TSC clinic, where they can do not only genetic counseling, but they can do dermatologic exam, MRI of the brain, abdominal MRI, echocardiogram, or other necessary assessments which are needed to make the diagnosis. And this is what is recommended by American Thoracic Society or ATS as well.
I have an aspergillus infection and need to suspend sirolimus due to significant interaction with the antifungal medication Voriconazole.
Voriconazole.
Thank you. I know the MILES study examined how long LAM patients can suspend sirolimus before their condition starts progressing. But could you please discuss the results specifically for pre- and postmenopausal patients, if the data was parsed that way, rather than just the average aggregated data?
So this answer requires little technical terms because you have asked for some specific numbers. So if it becomes too much like medical jargon, please let me know and I can explain it to you. But basically, this was the MILES trial, which looked at the efficacy of sirolimus in patients of LAM, and that was published in New England Journal of Medicine in 2011. University of Cincinnati were the main player. People from University of Cincinnati were main player in that trial. And Nishant, you can add if I miss anything. But anyway, according to the study, the premenopausal patients and, sorry, something happened here. Sorry, something happened to Zoom. Oh, did I go?
We can see you. We can hear you.
I lost it. Okay, anyways.
I think her note shut on her.
So anyways, it provides data on the suspension of sirolimus and its impact on disease progression. So according to this study, the premenopausal patients in the placebo group, they experienced a significantly faster decline in lung functions compared to postmenopausal patients. And if you look at specifically the numbers, when we do studies on a condition called like LAM, we look at this number called FEV1, which is forced expiratory volume. So when they do the pulmonary function test, they ask you to blow hard. So the amount of air or expired air or expiratory volume that is in 1 second is something that they are measured. If it is low, that means that there is narrowing in the airways or obstruction. So that is what they're looking for when they do these testing or when they carry out these trials. So the mean decline of FE1, I'm telling you the exact number, was -17 for premenopausal patients versus -3 for postmenopausal patients. So it was statistically significant. Now, upon treatment, when they started giving them sirolimus, both premenopausal and postmenopausal patients, they had a beneficial response. So premenopausal patients had a change in FEV1, which was previously -17 to -1 when they were on sirolimus. And in the postmenopausal, initially it was -3, while they were on sirolimus, it was 6. So +6, I would say. And so this indicates that sirolimus actually stabilize the lung functions and have a great impact on reversing or lowering the rate of decline when somebody is on sirolimus. Now, what they found was that after stopping sirolimus, the mean change of FEV1 from baseline to 24 months, it did not differ between sirolimus group and placebo group. So this suggests that the lung functions decline actually resumed at a similar rate for both groups after sirolimus was discontinued. Now, the other interesting thing was that when these studies are published, some of the nitty-gritty detail is put in a supplemental material that if you're really interested, you go and look into what happened. So when you look at the supplementary material, they showed that after the sirolimus was stopped, not everybody had a change in their lung functions at the same rate. Some had faster decline, some were relatively stable. So I think that is an interesting question for us to see that what are the factors that measure the rate of lung function decline after the sirolimus is stopped. There could be many factors. There could be their baseline FEV1. I don't know, maybe the genetics, maybe they smoked previously, maybe they were on sirolimus for a longer period of time. So basically, it does, on average, the lung functions does drop after stopping sirolimus, but it may not be at the same rate from one patient to another. There is individual variability. This was a long answer. I hope I answered it.
That was helpful. Thank you.
Another question about voriconazole or no?
About aspergillus reoccurring in patients on sirolimus, and if there's anything specific that can help prevent its reoccurrence.
Oh, yeah. So this was the next question. I thought it was the same question. Yeah, so there in the aspergillus infection, recurrence in lamb has not been quantified in the literature. They didn't, and I actually looked at even in the supplementary material of Miles, that patient who were on sirolimus, they got some infections, but didn't mention that how many were fungal, how many were because of aspergillus. But the interesting thing was that the rate of infections in the group which got sirolimus was almost similar as placebo. And I think I have this feeling that sirolimus is not a very strong immunosuppressant. So it probably does not increase the rate of fungal infection too much. But to prevent because the question here is not about sirolimus itself, it's about the interaction with voriconazole, and that is a true thing, that sirolimus does interact with voriconazole, and actually this antifungal medication, voriconazole, has a lot of interaction, and we see that in our transplant world, that they are always monitoring the levels of this drug when people are on voriconazole. So one thing I would say to prevent recurrence is to have, first of all, close monitoring and regular follow-up with pulmonologist and infectious disease specialist. There are certain other antifungal agents that can be considered. For example, capsofungin or amphotericin B, but they have side effects too. Like amphotericin B can cause kidney problems. And sometimes, there are certain environments where there might be more fungal spore encounters, for example, construction site or gardening, then I would avoid those kinds of exposures. Sometimes, not always, you can be on prophylactic antifungal, but we don't usually recommend when people are on sirolimus to be on antifungal therapy with it, but that can be discussed with infectious disease specialists.
Okay, very good. Now, a completely different topic. Can sirolimus cause hair thinning or loss?
According to FDA labeling for sirolimus, there has been mentioning that hair loss or alopecia is listed as a potential adverse effect, but it is not among the most common side effects, I would say. But yeah.
Okay. All right, Dr. Gupta, back to you. Does sirolimus cause osteoporosis? And at what age should women taking sirolimus begin bone density testing, and how often should it be done?
Yeah, good question. So osteoporosis or weakening of the bones, I'm not aware of sirolimus by itself being a major culprit as far as osteoporosis is concerned. But osteoporosis in general is a common condition and especially affects postmenopausal women as the most common demographic. So I think in general, regardless of whether you're on sirolimus or not, a good idea to talk to your primary care physicians about getting the guideline driven osteoporosis screening, especially for postmenopausal women. Now, other factors that drive osteoporosis tend to be if you're not very physically active, which any chronic lung disease, including LAM, can make you be less mobile. So I think people with more severe disease are more prone to having osteoporosis, and that perhaps may get conflated with an effect of sirolimus, but realize that that subgroup is also more likely to be on sirolimus. So I'm not sure that sirolimus is a cause, but to the latter of who should be screened for osteoporosis, I think every postmenopausal woman, and if otherwise you are not as active because of LAM or for other reasons.
Okay. And then the next question is about muscle loss. Could this be a symptom? There's a woman in her mid-50s that's experiencing muscle loss, and she's asking if this could be a symptom of LAM, a side effect of sirolimus, or is it more likely just part of the aging process?
Yeah, I think that's a good question and something that we perhaps don't pay as much attention to as we should. And I don't know that that's very specific to LAM, but this is something we see in general with any chronic lung disease, is that as you do less because you have a lung disease and you're unable to do things the same way to the same extent that you were doing before, um, we sort of adjust our lifestyle to what we can do. And over time, with that, you start losing muscle mass. And now you're able to do less, not because of just the underlying lung disease, but now because you also have the muscle loss that gets tagged along with it. And it can become a vicious cycle that or a downward spiral. Uh, so it is important to try to do anything and everything we can to arrest that, because otherwise it gets very confusing both for patients and for clinicians when symptoms are getting worse. And we always think about LAM, and you may end up titrating therapy, risking more side effects. But if the answer to that lies in not necessarily disease progression, but muscle loss, like, we are not going to achieve benefit from that therapy and risk more adverse effects. And so trying to stay active up front, trying to prevent that loss and that vicious cycle is a good idea.
Well, speaking of staying active, Dr. Kozlow, is there a specific type or level of exercise that helps maintain lung function?
Right. So I think Dr. Gupta really described the challenges that patients face, we all face, but especially patients. And so to answer this specific question, is there a specific type of or level of exercise that helps maintain lung function? If we take what Dr. Bakir talked about, we look at lung function with those numbers. So certain numbers, such as an FEV1, which is the amount of air that you can expire in 1 second, or FEC, the amount of air that you can expire over a prolonged period of time, typically 6 seconds, or diffusion capacity, which is how oxygen gets transferred from your lung into your blood vessels. So these are all numbers that we look at when someone performs a pulmonary function test. To the best of my knowledge, we would not expect those numbers to change or improve with exercise specifically. However, when you're engaged in exercise, so you're taxing your cardiovascular fitness and your muscular endurance, you should be able to do more work with the same amount of lung function that you have. And so the converse to what Dr. Gupta described of this cycle that we try to avoid of deconditioning, the converse would be training. And what is the impact of training? Not necessarily perhaps on lung function data, but other ways of measuring what a patient can do. And that can be measured in other ways. There's some questions on the 6-minute walk. Some people might do exercise tolerance tests where you might be on a treadmill or a bike. And there's other data that can measure the amount of work that a patient is able to do. So that's, I think, very interesting, and the effects of training on those numbers, what you're able to do, your muscular endurance, your muscular power, also quality of life and other fatigue, all play a role. So that's how I would answer that question, is not necessarily those numbers that we're looking at in, let's say, trials such as treatment trials.
And then related to that, we have a patient that says she's interested in doing pulmonary rehabilitation. Is there a specific type that she should be asking for that's best for LAM patients, such as cardio training, breathing techniques, etc.?
That's a wonderful follow-up question. And I'd be remiss if I didn't mention one of our colleagues, Dr. Mary Beth Brown and Claire Child, who have given talks in many different scenarios, including the Lamposium in our living room. I think that was a couple years ago. And in many different ways, I think she's been presenting this to the LAM community. So she would be an excellent person to speak to that, but I'll try to do my best to represent what she might say. So pulmonary rehabilitation is a problem because for many years it's been a center-based tool, meaning the patient with chronic lung disease has to get to a center to do pulmonary rehab. And typically a pulmonary rehab program is devised of a couple months with a couple sessions each week, where the session is typically 60 minutes divided usually into 30 minutes of aerobic exercise. So aerobic exercise is exercise that you can do for a prolonged period of time. And resistance training, which is more taxing your muscular endurance. And then each week, the patient in a formal rehab program should in some way be improving or increasing what they can do over time. And there have been studies not specific to LAM, but that the patients that get the most benefit from a program like that are patients that attend, I might get the numbers wrong, but I think it's something like 70% of those sessions over a period of time get the most benefit out of that impact. The second thing to note is that the patient has to continue in some way once that program is stopped. So there's always a transition from that center-based program to you managing this on your own and doing it locally or however you're going to do that. And that's very difficult for patients. So the first part is, how do you get to the center? And then the second part is, how do you continue that on your own? I think the uptake across patients with chronic lung disease, meaning patients that would be eligible for a center-based pulmonary rehab program, the number of patients or the percentage of patients that actually engage is very low, unfortunately. So what Dr. Mary Beth Brown did and her colleagues was look at how can we lower the entry into engaging in exercise. And then the second question you might ask is, are there any specific characteristics of LAM patients themselves that might be need to be addressed, such as safety? So that's what they did, and they have basically, it's not center-based, but mobile, meaning the patient is doing their exercise in their home environment, and they looked at what kind of exercises could be done, what kind of impact. So we talked about training. So, and then safety issues. So I'll speak to, let's say, a couple aspects there. I'll say I don't know specifically how those exercises differed from a traditional pulmonary rehabilitation, except to say that they also included aerobic and also included resistance training. There was no impact, to the best of my knowledge, on lung function. However, patients were able to do more, and that was manifested in certain tests like 6-minute walk test. Quality of life was impacted in a positive way. Fatigue is something that's commonly described, and my understanding is that despite doing fairly intense and consistent exercise, fatigue did not get worse, which one might be afraid of engaging in this kind of exercise program. So then specifically to answer the question is, are there specific type of exercise such as cardio or breathing techniques? I'll just stop and say that I think similar to any patient, to avoid this deconditioning obstacle would entail both aerobic training and resistance training. I don't know enough about breathing techniques, and I don't think that this was specifically looked at in Dr. Brown's work. I will mention one thing. Patients often ask me, why did the physical therapist teach me to do upper extremity exercises? And that's an important thing to mention, because some patients with lung disease, especially obstructive lung disease, begin to use or leverage their upper extremities in breathing. So that if we're engaged in certain exercise that also requires us to use your upper extremities, let's say, for example, cycling, if you have to hold the bike and also breathe somewhat with your accessory muscles, it's going to be very beneficial to train those accessory muscles, which are the muscles around our our back of our shoulders and our neck, or from the more mundane daily activities, such as going to the grocery shopping and holding groceries in your hands. So it's important to mention that lower extremity and upper extremity resistance training is also important. And I'll probably stop there.
Okay, that's good. And we do have the video from Dr. Brown's LILAR, Lymposium in Your Living Room, that Erin and I can make sure to send out when we send the link for this and any other follow-up information. If people are interested, you can watch it. All right, great.
I think the LAM Fit app is also very helpful. That is also Dr. Mary Beth Brown. And I think she also has a website or app, something like that, for LAM Fit. So you can look into that too.
Right, yeah, we'll get more information out on that. Okay, Dr. Bakir, is there any dietary or nutritional guidance that you would recommend for managing LAM?
So in general, the dietary or nutritional guidance would be the same as it will be for any person to live a healthy life. But in particular, there are some aspects in LAM, because especially people, if they are on sirolimus, the or high cholesterol or would be an issue, and that is why we monitor cholesterol levels or triglyceride level when people are on sirolimus. So a diet low in saturated fat and cholesterol, or rich in fruits and vegetables, whole grains, and omega-3 would be something to help manage the lipid levels. For immune system in particular, the recommendation usually is to have more vitamin C, vitamin D, zinc or selenium, or foods which are rich in nutrients, for example, citrus fruits or leafy greens, nuts, seeds, or fish. Adequate hydration is something that, or probiotic is something that is in general recommended for anybody who wants to have a healthy nutrition. And in particular, patients who are on sirolimus, it is recommended to avoid grapefruit or grapefruit juice, because it can increase the level of CYP3A4, which can lead to increased level of the drugs. Having said that, when I was looking for this answer, I should bring this to attention that there is on the LAM Foundation website, there is a handbook for LAM patients. It is very helpful. It addresses a lot of questions about how to lead your life, how to use oxygen, about insurance issues. I really like that handbook. On that, there is a very small paragraph about the nutrition, and I'm going to read that. So if you are taking medications, or even if you don't need them, you can always beef up, or maybe milk up would be a better term, your diet with calcium, an extra glass or two of milk, some hard cheese, a cup of yogurt or cottage cheese, or a bowl of ice cream can add much needed calcium to your diet. Just choose the lower fat version so you don't increase your weight and while you're increasing your bone mass. Dark green leafy vegetables like turnip greens, collard green, kale, and broccoli are good sources of calcium, as are shrimp, salmon, oysters, and clams. And don't just try to build bone, try to avoid losing it too. Smoking and excessive alcohol consumption can strip your body of much needed calcium, so eat smart and drink sensibly. So this is verbatim from that handbook.
Yeah, nicely written, easy to understand. All right, and then the next question was about the best supplements for LAM patients to support overall health.
I think that is almost the same as previous questions. So I would say vitamin D, omega-3 fatty acids, vitamin E, calcium, vitamin C, and probiotics. This is what I would say. I'm pretty sure there would be other things which are essential and healthy, but these are the main categories.
Right. Okay, and then can Aura rings or fitness trackers accurately monitor our oxygen levels while we sleep?
Yeah, so I didn't know about Aura rings up until last week. I saw in medical ICU a few people wearing the ring. I thought it was a new fashion, but anyways, I inquired at what are they wearing, and I came to know this was Aura ring. So anyway, so specifically Aura ring or any other fitness tracker, they have been validated for heart rate and heart rate variability, but they're not been validated extensively for oxygen saturation. And actually, there has been one study which indicated that Aura Ring could accurately measure your nocturnal heart rate and heart rate variability, but it does not address your oxygen measurements. And I actually, because the person I talked to in medical ICU, the physician who was wearing that, and he showed me the app, and it gives you a lot of measurements, but oxygen might not be accurate because we are concerned about nocturnal decrease or hypoxemia or decreased oxygen for LAM patients. I would not recommend using this as a sole measure for oxygen. It might give you an idea, but it might not be as accurate as your medical grade pulse oximeters. So I would not rely on it for oxygen purposes.
Okay, good to know. Okay, Dr. Coslow, back to you. Is there any research on the use of a CPAP for severe sleep apnea in LAM patients and its effect on the lungs or cysts? Also, is it recommended to have a sleep study every few years to help to monitor oxygen levels during sleep?
Right. So I think this touches a little bit on somewhat what Dr. Bakir mentioned. So just to take the first part of that question, I would think that the question is asking, is there any risk to treatment with CPAP in someone who has LAM who needs it? And so I don't know of anything specific to LAM or even to patients with cystic lung disease, except to kind of dice that up in its parts and say that we know that sleep apnea is associated with a lot of comorbidities, cardiovascular, metabolic, mental health. I mean, there's a fairly extensive list, particularly if you throw in that word severe, so if you define it. So anyone with sleep apnea, particularly severe apnea, I would think would benefit a lot more from treatment than not, for sure. And then the question is a patient with LAM and the extent of LAM or their history of LAM in any particular risk? I would also divide that up and say, well, like we say for most patients with LAM, if you're having any new symptoms that might be concerning, you need to evaluate that for a pneumothorax. And that would be where my concern might be with someone who's going to have positive pressure. So sleep apnea is typically treated with positive pressure or non-invasive ventilation. So you have a fixed pressure, and you can have a single pressure, which is CPAP, or bilevel pressure. Certain patients need higher inspired pressure than they do when they expire. So this question is asking more about CPAP. I would think that the pressure needs to be titrated to address the level of sleep apnea. I would think there is some potential theoretical risk if that pressure is too high in a patient with cystic lung disease, but I don't know of any specific studies or risks per se. I'd be happy to hear if my colleagues have anything to say about that. But I would pretty much summarize that I think you really need to have a close relationship, therapeutic relationship with their sleep physician to make sure that that titration is adequate both to treat your sleep apnea, but perhaps not too much. And usually I would think if it's too much, the patient is not going to be very comfortable with that device. There's a second part to that question, but I'll just stop there and see if my colleagues have anything to add.
No, not really, Matt. Agreed. And we have several patients who use their CPAP without any issues. If you have sleep apnea, good to treat that. Yeah.
Okay. And then the second part question is it recommended to have a sleep study every few years to monitor oxygen levels during sleep? So as Misbah mentioned, there are ways to track oxygen levels when you sleep, which is not really a sleep study. So a sleep study is looking at what we would define as sleep disordered breathing, whether there are changes in ventilation that may manifest as a change in oxygen, but that's very different than just measuring your oxygen through the night. As with most things, we want to screen carefully for someone that may have symptoms that would be suggestive of sleep apnea. That could be snoring. That can be something called a snort arousal, which I don't know if anyone's ever had that, where you kind of lie on your back and you kind of wake yourself up. That's highly associated with sleep apnea. And fatigue in the morning or feeling like you're not rested when you wake up in the morning. Those are all signs or symptoms that can associate with sleep apnea. And in those situations, you want a formal sleep study, whether that's at home or in a lab. And oftentimes we try to push for an in-lab study with someone with comorbidities such as chronic heart or lung disease. As far as, so should you do this routinely at any set interval? That I would say probably not. You should probably be seeing your doctor at a routine interval, and they should be screening for these symptoms that we just described, but I don't know about any random interval that should be done. As far as monitoring oxygen levels during sleep, that would be a nocturnal oximetry, much easier to do and get approved than a sleep study. That I probably would say is a low-hanging fruit. I mean, there's not much reason not to do that at some interval, and I certainly wouldn't. I don't know about every few years, but certainly if there's any clinical change or change in lung function, that might be something to think about.
Okay, good to know. All right, oxygen needs vary across different age groups. One of my main concerns is that the 6-minute walk test, which is often considered the gold standard for oxygen use approval, isn't an accurate measure of oxygen requirements for LAM patients. I've heard other patients express similar concerns. Is there anything being done or that can be done to address this? And could this requirement be adjusted or expanded?
Now, that is a great question because it is a huge source of confusion, I think, for patients and perhaps even some providers too. Those are very different tests. So there is something called an oxygen titration, and that is what is measured, that is what is used for oxygen approval. And so a patient would be started typically at room air and then exercise, typically walking on a flat surface, to measure how much oxygen, supplemental oxygen, if any, is needed to maintain that oxygen status above 90%. So that's a prescription. So you're measuring how much oxygen is needed at a level surface of exercise, typically walking. That's very different than a 6-minute walk. So if we order a 6-minute walk test, the provider has to specify how much oxygen the patient needs. So the initial test would really be that oxygen titration. If there's no change clinically, then a measure of let's say an endpoint, sometimes in clinical trials, or similar to lung function that should be done periodically, a 6-minute walk test might be used with a preset order of oxygen. So let's say I know that a patient needs 2 liters. When they exercise, I would pre-order that 6-minute walk test to be done initially with 2 liters. And then we measure how far the patient walks. So that's really the purpose of the 6-minute walk test. Of course, during that test, oxygen levels are measured to make sure that they're maintaining above 90%, but that would not be the test used to qualify someone for oxygen. So just to clarify the differences between those tests. The second part here is the concern about whether it's accurate measure of oxygen requirements. I think if the device measuring that is of medical grade, it should be accurate. Some patients, that's not true. Some patients, like the previous question, might have Raynaud's phenomenon, where they have a change in color or perfusion in their in their fingertips, where usually the saturation is put. And there are other ways to get around that, such as measuring it on their forehead or earlobes. Could this requirement be adjusted? Well, I think the level of desaturation is loosely associated with what you're trying to achieve. And we extrapolate a lot of this data from the COPD literature, which showed years ago that patients who are have chronic low oxygen levels at rest below 89% or more or less will benefit in a mortality benefit from chronic oxygen. As far as patients that require that only when they sleep or only when they ambulate, the data is a little bit less robust, but we do know that most patients can do more and feel better with that. And so I think that's where this kind of cutoff comes from. As far as adjusting it or expanding it, I don't think the data would speak to that.
Okay. Is there any research on the long-term use of progesterone-only birth control pills, TOPS, in LAM patients?
That's a tough question. I would answer that taking a step back and looking why is that an important question? And so I think that's an important question because oral contraceptives are typically combination based with estrogen and progestin. And we believe that estrogen exposure is associated with progression of LAM. So there is a recommendation to limit estrogen exposure, particularly with oral contraceptives. So an alternative treatment is oral contraceptives that are not estrogen based, and one of them would be progestin. So that's, I think, the rationale for why someone is asking that very important question. As far as is there any research on the long-term use, I would think the question might be asking, is there any research on the risk of that use? That's my guess about what's behind that question, and I don't know.
All right, one more for you, Dr. Koslow, before we give you a break. Is there any difference in the progression or long-term side effects of LAM when choosing between a myomectomy, uterine fibroid embolization, or a total ovary-sparing hysterectomy to treat large, painful fibroids? Are there any specific considerations for LAM patients when deciding which option to pursue?
Right, so I think that somewhat touches a little bit on the mechanism and the rationale behind the previous question. So is there any difference in the progression or long-term side effects of LAM with these various potential procedures to treat large painful fibroids? So that's the first part of the question. And I'll also take a step back and say that to the best of my knowledge, so the rationale, of course, speaks to what we just discussed about limiting estrogen exposure. So it's a logical question. And then the second question would be, is there any data for these type of procedures having an impact on LAM? To the best of my knowledge, there have been very small studies or let's say what we call case series or studies of a small number of patients. To the best of my knowledge, they have been varying in their results or implications without any firm or definitive implications for management. And the second part to that is, I think the general approach is that those procedures should not be engaged as a way to manage LAM. The second part to that question is, well, what if there is an independent indication for those procedures to treat a condition such as fibroids? And that I would think, but I'd be very interested to hear what my colleagues say, would necessitate a close and thoughtful conversation with the obstetric gynecologist that would be treating that patient, as far as I would think, what is the least invasive and most effective procedure to manage the condition. Other than that, I would think it would be an independent decision about what is necessitated to treat the condition and what would be least invasive for the patient.
Great.
I don't
Dr.
know what my colleagues might have to input, because that certainly is an important question.
Yeah, I don't have anything else to add. This was very well said, and I would treat them as independent indications, as you've already said.
Yeah, I would consider that, I would talk to OBGYN person and discuss in detail. I think it should be a multidisciplinary approach, but I would not take it as a treatment for LAM. I agree with what Matt has said.
Okay, Dr. Bakir. I was diagnosed with LAM several years ago, and none of my scans have shown any angiomyolipomas. Is there still a chance that they could develop in the future?
Yes, AMLs can develop anytime in patients with sporadic LAM. According to some studies, the chances of AML is about present in 50% of the cohort, and their presentation can occur up to like many years, or even up to like 40 years after the onset of lung symptoms. So yes, it can happen anytime. That's why periodic screening is needed for LAM patients.
My LAM has been fairly stable since I was diagnosed about 10 years ago. How frequently should I be getting CT scans? I worry about the radiation.
Yeah, that's a very good question. There are certain patients, especially postmenopausal women, where it doesn't progress as fast as in premenopausal patients. And in stable LAM patients, I think the frequency of high-resolution CT scan should be decided on individual basis. If somebody has, I mean, it also depends on a lot of things, like whether they have symptoms, whether they can perform pulmonary function test, if they were on mTOR inhibitors, how was the response to treatment, and development of other pulmonary complications, for example, the chylothorax, etc. But I think if somebody's pulmonary function tests are stable for years, then decreasing the frequency of high resolution CT scan makes sense. You can do it like every, say, 3 to 5 years, or even like longer. But because there is the risk for radiation is there, and if I were a LAM patient, I would be concerned about that too. So I would space this out and rely more on symptoms and pulmonary function tests.
to know. Okay, Dr. Gupta, back to you. Can you start hormone therapy to manage menopause symptoms while continuing sirolimus? Will sirolimus help manage any potential lung decline that the hormones could cause?
Yeah, good question. Unfortunately, with no good answer. So I think first and foremost need to really very carefully parse out what are the symptoms, what that we are trying to address. If it is, let's say, vaginal dryness that you're dealing with, you could certainly use a vaginal estrogen cream, and those are safe to use. The amount of absorption of estrogen from those creams into the body is very minimal, and that doesn't have any known deleterious effect on lamb. There are a number of other non-hormonal treatments, including supplements, prescription treatments, as well as a very new non-hormonal prescription treatment for handling postmenopausal symptoms that has just come on the market. So I think it's good to talk to your physicians about that. The concern with the traditional hormone replacement therapy is that the estrogen component specifically, that we fear that might worsen the progression of LAM. So that's generally something we like to avoid. And some people may already know it. There is a women's health subgroup working committee that was recently formed by the LAM Foundation leadership to help us sort of think through these things and carve out a plan for better answers to these questions. I actually came across this resource as part of just our initial meetings through this working group that I can try to enter in the chat. Oh, well, the chat is disabled. I'll send it in an email.
Yeah, if you send it in an email, Dr. Gupta, we can send it out with the notes after the meeting.
Yeah, and that's a very useful link about menopause and what symptoms, how you can manage symptoms, including a list of medications, etc. So I think that can provide a very good starting point and a lot of information that you can then take to your physician and discuss. The second part of this question, can sirolimus be used to counteract any deleterious effects of hormonal replacement? Meaning, could you just do both? That's a very intriguing question. We just don't know the answer to it. A close parallel to that one might think of is what might happen in pregnancy, that someone might take sirolimus during pregnancy, and can that have the same effect as this question is asking? Again, we don't know that yet. Dr. Bakir was involved in a recent sort of collaborative endeavor where we pooled data from about 9 or 10 women who have used sirolimus during pregnancy, and the prelim results from that certainly suggest that this approach is safe, but that data is derived from such small number of patients that I hesitate to extrapolate it to everyone. So for the time being, I think I'll defer to the earlier part of this answer, which is to think about all other non-hormonal interventions first. And there are a lot that are available.
Okay. Great. We hear a lot about what's being done for the needs of younger LAM patients in their childbearing years, but many LAM patients are well past menopause. How is this generation of patients doing, and how are they managing their LAM symptoms and disease progression?
Yeah, good question. I think it's we touched on some aspects of it already in the first question, and I promise I'll send that website. I actually found that website to be tremendously helpful for myself. So and I've already conveyed it to others at the foundation that we really need to broadly share it. So I'll be happy to send that link out. The other thing to this question is something that Dr. Bakir already covered, which was that in general, we think the disease progression is slower post-menopause than pre-menopause. For example, in the MILES trial, the postmenopausal women declined at about 5 times slower rate than premenopausal women. But both groups had benefit when treated with sirolimus. So generally, we don't if someone otherwise qualifies for treatment, we don't not prescribe it just because they are postmenopausal. A related question to this that often gets asked is, I used to be on sirolimus for a few years. Now I'm postmenopausal. Can I stop taking sirolimus? Or can I reduce my dose? All very good questions. We think about it a lot. We talk about it with our patients on a regular basis. I will say that we generally, considering the overall safety and tolerability of sirolimus, we don't tend to stop drug after menopause if someone is otherwise tolerating it well and doing well on it.
Makes sense. Okay, Erin, this is our last pre-submitted question. If you want to open the chat box. What is the status of the SOAR bill that Bev Jackson and Karen Kinsey have been advocating for?
Yeah, actually, I think there are better experts than me on this call to answer this, considering I see Bev is there, and I think I saw Karen as well, although the list is too long for me to scroll through now to find out. So I first wrote to Bev asking this question. Bev pointed to me that Karen and Susan Jacobs at Stanford are leading this initiative. So I wrote to Susan next, and she sent me an update that I can provide. And I'll try to summarize this, which is that the SOAR Act didn't make it through last year, but that there is a lot of momentum gathering for reintroducing it this year. And another part of this answer was that the patients should be encouraged to contact their local representatives to support the SOAR Act, and that they are still collecting patient stories about problems with oxygen. And Karen, I think, is the LAM Foundation representative for this group. Karen Kinsey, I think, is on the call. And the other update that Susan wanted me to share, which is related to oxygen, is that she's been hearing from patients that if your battery is more than 160 watt hours on the POC, or the quote unquote double battery, that some airlines are apparently not allowing patients to use that. I wasn't aware of this until Susan sent this email to me in response to this question. And her suggestion was that if you're contemplating flying, just contact your airlines in advance to make sure you know their regulations around oxygen and what batteries they may or may not allow you to take. And Bev or Karen, please feel free to update with anything that I might have missed here.
Karen, are you there?
Yeah.
Do you have any? There
Well,
you go.
I have dropped off of being that advocate person, and Karen is the current one for our Lammy's group. But running on air is putting together something about this battery issue, because there have been people who have been confronted because their batteries were not meeting the airline specifications. And I am sure Mary will be coming out with something that we can publish soon about the batteries.
Great. That would be helpful for a lot of people. Yeah. Okay. Well, we have a lot of questions here in the chat box, and we also had some submitted by email. So we'll start working our way through them here. We have 3 about vaccines. So or 3 or 4. We're going to work through those first and then jump over to the other topics. Given the immunosuppressive effects of sirolimus, should LAM patients receive an MMR and/or meningitis booster if they have already been vaccinated in the past?
I think on the LAM website, there is a whole document about vaccinations, which Dr. Kotloff from UPenn have put together with other people. So I think I can open it up. I think that answer is yes, but I can, while you are discussing other question, I can look it up for specifically for the boosters.
Okay, the next one is about the measles, and if Lyme patients should be getting boosters for that, since there's been a couple states with outbreaks of measles.
I will open it up. Just,
Sure.
you can move on to other question. I
Get
can,
past the shots and go on to something else? Okay. Let's see, our next question is, Lyme clinic doctors have ruled out other potential diseases as the cause for my more than 500 cysts in my lungs. Given that the VEGF-D test came back negative, is there any other way to obtain a definitive diagnosis besides a lung biopsy? I'm postmenopausal and all other symptoms point to LAM.
Sharon, you may have to make executive decisions about who you're assigning each question to.
Okay.
Mm.
Since you're talking, Dr.
But
Gupta.
yeah,
That one's
no,
to you.
yeah, no, I figured since I said that this gonna come to me, but that was more for the next questions.
Yeah, the next one I'll assign.
I think if you have exhausted all other non-invasive options, then I think the definitive way to diagnose this would be via a biopsy. We generally do take a step back before reflexively going to a biopsy in these situations, though, to ask ourselves, is getting a definitive answer going to change what we do? For instance, if we know that someone has mild disease or they don't have symptoms or where we would not start treatment, we often are comfortable with some uncertainty and say that we can serially follow and not necessarily go through a diagnostic procedure. But if we know we are going to treat, then in these circumstances, you need to do a biopsy. And sometimes that uncertainty is okay with us, but not okay with patients. And that's not necessarily wrong either. And if that's where this person is, then I think, yes, it's also okay to proceed with a biopsy in that circumstance.
Okay, Dr. Did you get it, Dr. Bakir?
yeah, what was the question?
It was MMR or meningitis booster.
MMR is, so that if somebody is on sirolimus, then the live vaccination should be avoided. And MMR is one of them, so they should be avoided. But regarding the, if they're not on these medicines, then this would be discussed with the primary care doctor, or what is the situation of measles around it. And if somebody wants to take the booster, I don't think so anybody would say no, but you should not be on these medications for live vaccinations.
Okay, and that's the same for measles too, right?
That's measles, mumps.
Measles is a live vaccination as well. And then RSV, there was a question about if patients should get the RSV. We talked about COVID, you should get the COVID booster.
RSV, yes. If they're above 65, they should be getting RSV.
I think the document on the Lyme Foundation site says not before 65 for RSV.
The FDA approved 2 vaccinations for prevention of serious respiratory infections from RSV in adults age 60 and older. So practice recommend that individuals deemed by their healthcare provider to be at increased risk for serious infections strongly consider receiving the vaccine. So 60 and above.
Okay, 60 and above. Okay, and then COVID boosters for people on sirolimus?
Yeah, they can take it.
Get those. And then how often should you get the pneumonia booster?
So pneumonia booster it depends on which is it 23 or 13, depending on that, or whether which one they were vaccinated with in the past. That is dependent on that. So individuals who have never received, so this is a long document because it is dependent on their age, and it is dependent on which was it PCV13, PCV20, or which one is that? So it's a long document, but it's there in the document. So I would decide it based on individual basis about pneumonia vaccine.
We'll attach that to the notes when we send those out so people can go back and reference those. I remember that being a big section when I looked at it last time. It's been a while, but yeah, there's a lot of details behind it.
I might chime in also. The CDC has a great app it's called Pneumorex. So just Pneumorex, PNEUMORECS, just kind of stepwise walks you through the pneumonia vaccinations.
Oh, that's great. Thank you. Well, since you're talking, Dr. Koslow, This could be the next question. As a lamb patient, I've been working remotely to minimize the risk of getting sick. While I agree we shouldn't let lamb control our lives, I also have rheumatoid arthritis, Sjogren's, and a central vestibular system disorder. Given these conditions, avoiding a petri dish work environment seems to be a prudent choice. I was concerned about potential risks even before COVID. My lamb is stable right now. I'd like to keep it that way. What are your thoughts?
So, wow.
So
That's a
long.
tough question. I don't know if in the question the patient commented on whether they were on sirolimus or not. But I guess the second question, should it matter?
I don't
So,
see that they're on sirolimus, no.
so say it one more time. So the question was how,
So she's got rheumatoid arthritis, Sjogren's, and central vestibular system disorder. And she's worried about, on top of lamb, and she's worried about keeping herself healthy. Is it best to stay out of group environments like the office, or is she just being overly cautious, I think is her question. And I think a lot of people have that same question.
yeah. You know, I don't know how to answer that without knowing the patient that asked the question, and I don't know if there's a great way to answer that question except for the way I approach it in my practice, which is I think it's really important to have a relationship with your clinician, because these are personal decisions of weighing risks that we all make. When I go to the airport and I'm on that train, I wear a mask. I don't share those comorbidities. So I think the way I would think about that question would be that it's really important to have a close relationship with your provider, to share your concerns, and probably to try to be as informed as possible about what those risks are in different situations, and make those calculated risks. For example, in the work setting, just for example, you have to balance the social benefit from working with colleagues, which I think is important, versus any potential risk that might be in such a social setting. And the same might be said for any social gatherings. I don't know. I'm a little stuck to answer that question. There's risk for sure, and this risk also varies with certain circulating respiratory viruses such as the flu, and being exposed to certain situations with little kiddos and things like that, and trying to be informed about minimizing that risk. It's probably the way I would approach it. I don't know what my colleagues might say.
I would say individualized decision, but say I had a lamb or I had a lung condition that would make it worse if I am exposed to infection, I would wear a mask. But that is me. I'm saying, but like for example, now I was in hospital last week and I noticed that influenza was going on, and a lot of providers were wearing masks. It's not mandated. I mean, it's a personal choice. So if somebody has a lung disease, I would probably do the same, that I would wear a mask.
I hope I mentioned mask. If I didn't, that's what I meant.
Right, thank you. Dr. Gupta, is lamb considered a low-grade cancer?
Yeah, good question. And when I see patients in clinic, especially if I see new patients, I do bring this question up unsolicited, even if patients don't ask, because someone is going to mention this, and I always tell them it's better that we have this conversation now in the clinic rather than someone finding it on the internet. The short answer to this question is yes. That's about the shortest possible way to answer this question. But I think there are a few caveats to this that need to be understood. Anytime you use the word cancer, it rings all sorts of alarm bells, and it has very negative connotations about how we view or think of cancer in our common parlance. but LAM is a low-grade cancer in that biologically the LAM cells behave like cancer. They have a mutation, they start somewhere, they go elsewhere, etc., etc. But it is different than the way we think of cancer in that typical cancers have hundreds of mutations. They tend to be more aggressive. They tend to be more resistant to treatment. LAM in that context is, if I could even use the word simple, is simple or simpler than those cancers. It has one mutation, and one mutation drives everything. It is not so aggressive. The average survival in women with LAM, even in the absence of treatment, is upwards of 25 years. So yes, biologically, LAM is a low-grade cancer, but it does not and should not be conflated with the other common parlance of how you think of cancer.
While you're there, why don't we have you do the next one too? What effect does a person's height and weight have on PFTs?
Yeah, so these factors might affect how we would compute someone's percentage predicted. And height certainly does. Weight is not taken into account in that equation of percentage predicted. But in general, a lot of times in the clinic, when we are comparing what is happening over time, we just take the raw values, and that raw value is the raw value, and that is not going to be affected by the percentages or the equations used to calculate those percentages.
Dr. Bakir, for LAM patients who are pregnant, are there recommendations for C-section rather than a vaginal delivery due to risk of cyst rupture when pushing during vaginal delivery?
I'm not aware of it. I think, again, it should be discussed with the OBGYN person, but I do not think that if looking at all the risk factors for pneumothorax or rupture of the cyst, air travel comes number one, but I am not aware that pregnancy is one of them. So I would decide, like for any normal person, that if vaginal is needed or C-section based on other factors. I do not think that having LAM would be a factor in deciding that, but I might be wrong. Nishat, do you know anything about that?
I agree, Ms. Pa, and we also tell patients that the decision to do C-section versus vaginal delivery should be based on obstetric indications rather than LAM indications.
There's some questions about clarification on COVID and flu vaccines. If you're on sirolimus, should you continue to get both of them even if you're on sirolimus?
Yes, both of them. They are not live vaccinations, so yes, they are recommended, but again, they are not mandatory, but they are recommended. But flu should be taken every year.
Yeah. Dr. Kozlow, is creatine supplement to help increase muscle mass safe for LAM patients to take?
Safe. So I do not know of any data that would be unsafe.
Okay, fair enough. And then since you were talking about exercise before, Dr. Kozlow, why don't we give you this next one too? Could you expand on resistance training? Does it pose a risk for pneumothorax? For instance, would using a reformer Pilates machine be considered safe? Additionally, when it comes to lifting weights, what is the recommended maximum? We have been advised not to lift more than 1.5 kilograms. Oh, it must be from Europe. Okay. Can you provide guidance on this limitation? Furthermore, could you comment on the use of Power Breathe for pulmonary rehabilitation? Is it beneficial, and are there any precautions we should take? That's a lot of questions in there.
Right. So I'll just tackle this. I think, as Dr. Gupta mentioned at the very beginning, we want staying active for cardiovascular fitness and resistance training, weight-bearing exercise is all really important because the impact of training on our health is very important, and also to combat that conditioning. So I'll start with that. Does it pose a risk for pneumothorax? As Misbah said, I think Well, I don't know of any data where specific exercise has been associated with increased pneumothorax in LAM patients or other patients with cystic lung disease. That said, it might be worthwhile to just mention you're using your judgment and using very heavy weights. And just intuitively, what I tell my patients is you want to avoid Valsalva movements where you're holding a heavy weight and holding your breath. You want to be properly trained about how to exercise when you're using weights. And then I'm not an exercise physiologist, so I think there are many ways to train your muscles, and that doesn't necessarily relate to the amount of weight. So I'd really defer to the experts on that, especially Dr. Beth Brown, who's been working with that. I did ask her, I would think we would know about this, but I don't know in her program if anyone has suffered a complication. I don't think so. But that would be one way where I think is the incredible value of her work is to help lower the entry for patients to engage in exercise. As far as a weight limit, 1.5 kilos, I don't know of any, again, arbitrary weight to avoid, but I wouldn't necessarily be a proponent of lifting heavy weights to get the effect that you would need. Pilates sounds great. My wife's a Pilates teacher. I think that's great. Again, Pilates is great exercise. I don't think anything specifically there would be a concern in my limited experience. And then I'm not familiar with Power Breathe. Looking it up, a breathing trainer. I'd have to look that up a little bit.
Okay,
So I'll do
Fair.
that.
Yeah,
Okay.
and hey, Sharon, as Dr. Koslow is looking it up, can there are other questions related in the chat. Can I just give a very overly simplified message that I give to patients in general in clinic?
Yeah.
Which is that it is bad enough that someone has diagnosed you with a rare lung disease. We do not want to overcomplicate it by any restrictions on your life. So from me, the answer is very simple. Except for scuba diving, there is no restriction, whatever you need to do.
And skydiving, right?
Like that.
And yeah, probably don't jump out of a plane is a good idea anyway.
What about roller coasters? We get that question a lot.
If you enjoy it, I don't know that I want to take that away.
Okay. All right. Let's see. Dr. Bakir, what should we do if we contact COVID and we can't take, is it Pavlosic?
Paxlovid.
Yep. I have been told to go to the hospital, but what do I suggest they use for me?
I'm not sure whether we are. So first of all, it depends on how severe it is, the COVID. If you are having decrease in oxygen, then a 10-day course of prednisone or steroid is recommended, usually dexamethasone. If your oxygen is below your usual level. In cases of LAM, obviously it's a cystic lung disease, and somebody is COVID and is having a lot of symptoms, Paxlovid can be considered, but if Paxlovid due to some reason is not given, then I am not sure currently they are giving those antibodies that they used to give before. Does anybody know? Those
Say again, Misbah?
the antibodies that they used to infuse
Oh,
COVID patients. I do not think I'm
so
not.
only in pre-exposure, the Pemgarda.
What did you say?
Oh, the only thing that I know about is the pre-exposure Pemgarda for patients that are more severely
Monoclonal antibodies
Yeah.
for COVID infection. I'm not sure whether they are still giving it because I've not heard of it. And COVID is not as severe as it used to be. So that was in the first or second wave they used to give it. And this other one, this molnupiravir, I have not heard it given too often these days. Does anybody of you have any experience?
Yeah, Ms. Pai, I've given the molnupiravir, which is the Merck drug, to a couple of patients who couldn't take Paxlovid for other interactions. They were able to tolerate it well. This drug is less efficacious than Paxlovid, but generally otherwise seems to be safe and well tolerated. The other question that commonly gets asked to me is why, and worth thinking about, is why can't you take Paxlovid? And it is a very short course. Often the answer is because of a medication interaction, and it's worth asking if is that other medication necessary for those 3 or 4 or 5 days, or can you just hold that other medication and take Paxlovid? And we certainly employ that same approach for patients who are on sirolimus. So I personally don't consider the background use of sirolimus to be a contraindication for the use of Paxlovid.
We're almost out of time here, so why don't we try to get in one more question, and then Erin, can we save these so that we have them to refer back to?
Yes, of course. I'll take any of the questions that aren't used and follow up.
Okay, thank you. So let's, Dr. Gupta, if you don't mind circling back to RMC 5552, and what will the next steps look like? What does it take to bring a compound like this from research stage to developing a clinical trial?
Yeah, good question. You know, the next steps generally go in a very phased manner, which is that if we think a compound has potential benefit, you start off with testing it in a very small cohort of patients. And at that point, we are just trying to see, is this drug safe? Is this something the patients can tolerate without any bad side effects? And we're not even necessarily looking for, is it making any meaningful change in the disease? Although we collect that data, and if there is something meaningfully that changes, we can't make too many inferences, but that certainly boosts our confidence. And if that stage is passed, meaning the compound is safe, well tolerated, then you design a larger trial where it is designed with testing the efficacy question in mind, which is that, is this drug going to be helpful for patients? We again test the safety aspect on that trial as well, but that then becomes the secondary measure and the efficacy becomes the primary measure.
Okay. Great. Any last words of wisdom that the doctors would like to provide before we wrap this up? Yeah. They've given all the wisdom they can give for one day.
Well, from my side, I think just 2 things. One, a note of gratitude to everybody in the LAM community. This is we say this often, but but this is a true partnership, and patients have been a major engine that has driven the success in LAM, and will continue to that will continue to be the case going forward. And the second is just a very simple note of optimism that, you know, LAM has achieved a lot more than most other rare diseases ever achieve. So that's something we should be grateful for. And with the amount of discoveries that are happening on an everyday basis, the future of LAM is bright. It's very bright. So that's just something I think is also worth remembering, and we lose focus on that somewhere.
That's a great optimistic note to end on. That, and the fact that, as Dr. Gupta brought up at the beginning, we do have our International Lamposium coming up in September. For the first time, I think since 2022, we'll be having this one. This is the 30th year of the LAM Foundation. It's September 26th through the 28th in Kansas City. And I believe, Erin, to correct me if I'm wrong, but I believe registration starts in about 3 weeks, around the 24th of March.
Yes, and everybody should probably be receiving an email within the next week or 2 about financial assistance as well. So that more will be coming soon.
Great. Well, thank you very much. I think we can wrap it up. Thanks for giving your mornings to us today. I hope you all learned a lot, and thank you so much to the doctors for all the work you put in, all the research you put in, and all that you do for the LAM community. We just appreciate you so much.
Thank you for putting it together, and thank you for
Yeah.
all. We learn equally from you. It's not that.
It's mutual.
Great, thank you. Thank you, Erin.
No problem. Thanks, everybody.
Okay.
Bye-bye. Have a good weekend.
Thank you.